And finally, Jacques Duranteau about vasopressors in hemorrhagic shock. So we will start first. Thank you, Gernot.
Cher Antoine, cher Peter, merci beaucoup pour la invitation à Paris. Alors, unfortunately, I'm not able to speak French so well that I can confront you with that, so I have to switch to English. Thank you very much. I'm very proud to be here. It's a great pleasure and honor, and to be part of the first joint session. You came to our conference last month to Leipzig, and I think it's brilliant that the two intensive care society of Germany and France are joining now closely together, and I'm looking forward to a bright future of this development. Now, I have to start with some conflict of interest, especially here. I think B. Braun and Edwards are the two main ones. They gave me some honoraria for lecturing and consulting also. Now, when we talk about fluids, I just heard you had yesterday a great debate between colloids and crystalloids, and when we talk about now the situation of shock, we maybe have to be clear what we are talking about, and I will use the 20 minutes I can share with you some of my thoughts, and maybe they are not only data from the trauma, but I think some general views on the fluid therapy, obviously, which are clearly transferable to the trauma scenario as well. So first of all, when we talk about fluid replacement, we talk about renal enterodermal losses, and we know that this crystalloids we use there then are distributing in the intravascular and in the interstitial space, filling up the extravascular compartment. Whereas when we talk about volume replacement, this is loss of the intravascular compartment, and colloids are aimed to contain, because they're containing oncotic substances, that they ideally stay longer in this intravascular compartment. And what we want to achieve, and I think this is very important, that we remind ourselves to that, is normovolemia. And obviously we have to dilute then the remaining blood when we want to achieve this game. One thing is very important to realize. Basically, it's about bringing oxygen to the cells, and not only to the cells, but to the different parts of the cells, hence, for an example, mitochondria. And the problem we always have, that we measure it maybe here on this level and on that level, but to be honest, we do not know when we give oxygen towards the cells, when we keep up the pressures and the flow, whether this is doing something good or not. And especially in the situation of shock, it is even more complicated. So we have to be clear that what we are measuring is the surface, and we hope that here, where the oxygen is really needed, it will be then coming to. Secondly, this is always true in emergency medicine and intensive care medicine. We do not have time. The time when there is an oxygen depth needs to be as shortened as possible. And we are talking about minutes and maybe a couple of hours, but not about 10, 12, 18 hours. But it's the shorter the duration of time of oxygen depth, the greater the chance that we avoid that the cells are basically necrotic or apoptotic. And when this is the case, when there's the number of cells are huge enough which are necrotic or apoptotic, then you have organ dysfunction and then organ failure. And when you avoid this, if you keep that short time and the amount of cells are limited, then obviously organ dysfunction can be resolved or even is not initiated at all. So time to keep the time of shock as short as possible is the key issue. And the other thing is, obviously then in the end, when there's tissue hypoxia, this is then the final route. You have different scenarios of shock, septic shock, trauma, hypovolemic shock, hemorrhagic shock. In the end, when there's tissue hypoxia, we are not so, our body is not so, our pathophysiology is not so complicated. In the end, there's tissue hypoxia, and it's the end goal, and usually similar things are going on, and organ failure happens in the end. So I have to confess I'm still using colloids in shock, and I show you this is not from trauma, but I think it is from septic shock. But the thing is this is even, I think, more true in hemorrhagic shock, that initially colloids staying in the intravascular space. This is a study of Dutch colleagues. So Jan Groeneveld is one of the very famous ones from the Netherlands. This is not evidence, this is pathophysiology, okay? So there are just 48 patients, some septic, some non-septic, crystalloids versus colloids. They used the delta CVP over 90 minutes, and the outcome measurement was cardiac output and volumetric, so global end-diastolic volume. These are the septic patients. These are the ones receiving crystalloids, 3% increase of the preload and cardiac index. Septic patients, 12%. That means if you give in the early, this was early stage of shock. In the early stage of shock colloids, it stays in the intravascular space, increases the preload, and this Frank-Starling curve goes up, and you achieve exactly what you want. You increase the DO2 by increasing the stroke volume. So in the initial phase of shock, colloids are working as they should. And even in sepsis, there's not straight away the increased capillary leakage. And this is even more true in the hemorrhagic shock, where this is not such a problem as in sepsis in the early stage. What about monitoring? This is complicated in the ICU, even more complicated in the trauma scenario. Do you use mean arterial pressure and heart rate? I do, I confess, but if you think about it, these are very old data, but I continue to show them as long as we continue to doing so on our units. This is the cloud of, it's not a correlation, the cloud between mean arterial pressure and DO2. You feel happy for the patient if the mean arterial pressure is 75. You have no idea whatsoever what the DO2 in this patient is, other you measure it. And the same applies for the heart rate. You feel fine if the heart rate is maybe 85 or 90. You can have any DO2. What about CVP? You can have any CVP, you give fluid, and you do not know whether this is a fluid responder or not. So all the things we're usually doing, they are meaningless. We should just stop to use it. I mean, pressure, for example, is important to have then perfusion pressure. Yes, this is true, but nothing to do with the DO2. Then we have to measure flow-derived parameters like stroke volume, cardiac output, maybe lactate, okay, these kind of things. And what I really highly recommend, and it won't be so long, and then this will be within recommendations, I guess, is the passive leg raising. And there are several publications, especially from your country, and this is something we can do on the unit, and this is something you can do in the emergency situation, either on the street or in the emergency room when the trauma patient is coming, and you know whether this patient is really in shock and need fluid or not. So you just have to increase the legs, and then you see whether the cardiac index or cardiac output increase or not. Obviously, we have here a problem, ladies and gentlemen, because usually in the emergency situation, we do not measure cardiac output. And this is true, and this comes from my department. So we have now discussed and using this sort of algorithm for fluid management on the unit, because It's the same when a patient comes from the normal ward to the ICU. In the initial state, we have mean arterial pressure and we have heart rate and nothing else. But when then the mean arterial pressure increases by more than 10%, I know this is debatable, but then we give fluid and we try to install as soon as possible something to measure the stroke volume. This can do the Doppler, this can do a pico, this can do what's Vigileo, whatsoever, what you like. Yeah. Obviously, you can use echo as well in this situation if you have this present. But in the initial phase, in the emergency situation, I think even if it's non-invasive, the increase of mean arterial pressure when you do this, I mean, best is really you have the A line in. Then you know that the patient is fluid responsive and needs fluid, is in shock. And ladies and gentlemen, this is the main criticism in all these large fluid trials, 6S, bicep, chest, even in crystal, which is a better study than the others, that there's no indication for fluids. We use fluids by CVP, but we do not have the indication. And one indication, and especially for colloids, in my view, is shock. But we have to prove that there is indication, and I think really passive leg raising is here not ideal, but the best what we have got in our hands. And you can just do it, try it out on your units. It works fantastically. Sorry for the germ there. Another thing is, forget about the abnormal saline. Please use balanced solutions. So if you have here in this JAMA publication, it's a prospective observational trial in more than 1,500 patients, pre-post designs, so not the best methodology, but first it was based on abnormal saline, and then the second phase was chloride restrictive. And you can see here, if you use chloride restrictive fluid regimen, then you avoid the chloride increase and hypochloremic acidosis. And this is not an academic thing. You avoid renal injury and renal failure. So these are rifle classes. Injury and failure was significant in a pool of 1,500 patients. So you can do here a clear something good for the patients. You can avoid harm, and this is true in all shock scenarios. As long as you use a lot of fluid, and especially in trauma, we have no data in trauma situation, but why should this is physiology, why should this differently in trauma patients? And basically they do not cost anything more. Just forget about the saline and use balanced solutions, crystalloids and colloids. We can skip that for time. Now, one study a couple of years ago, PI was again from your country, Friedrich Schottgen, and this was a trial from the European Society. 822 patients, crystalloid colloid study group, observational trial, all shock patients over a period of 4 weeks, again observational trial. But in all these observational trials in fluids, there's one main advantage. Patients were observed the whole time. Your crystal study is the first one which really included the shock time. In all the other trials, which started 10, 12 hours afterwards, the shock time was already done. Patients were treated. So we do not have a good idea what is really the advantage of colloids or maybe the disadvantage of colloids. Very interestingly, in this observational trial was that here, these ones, this is hyperoncotic albumin. This was significantly associated not only with renal adverse events and dysfunction and more renal replacement therapy, whereas all the artificial colloids and crystalloids were lower here. It was even associated with an increased 28-day mortality. I know there are now prospective data, not published yet, showing, let's say, a different signal, but this is also a signal. And we should be very clear that in my view, albumin is not so, let's say, neutral, or you just, now let's switch to albumin. It's not so easy as sometimes written. Another thing is the SAFE trial. You know why the Australian colleagues performed the SAFE trial? Basically, there are ex-United Kingdom inhabitants, and they were sent to Australia because they were prisoners, so exile. And then you know that the Australians think they are the best intensivists in the world because they have very good outcomes, and they were always using 4% albumin. And the British people said in 1998, the Cochrane analysis, you kill patients using albumin, and they think this was just not true. This was the initiative for this very first large trial of Australia. And they compared 4% albumin against the worst crystalloid I know, abnormal saline, and there was no difference. When you see here the sub-analysis, and they were predefined, so they could do that, of trauma patients, this was nearly significantly, but this was against the colloid. And they looked in this particular group of patients a little bit deeper, and they found that in traumatic brain injury patients, the use of 4% albumin was deleterious. So you can see here after 700 days, a huge difference in mortality against albumin, which led to the recommendation of some colleagues as a consensus statement. We recommend not to use colloids in patients with head injury and not to administer gelatins. So taking this result of albumin and just across all the colloids. We have to be clear about one thing here. There is a clear difference between peripheral capillaries and cerebral capillaries. Obviously, here we have the large molecules, colloids, and the oncotic force. Here in the cerebral area, we have the we have here the tight junctions, or here or there, and so the osmotic force is more driven by the small molecules. So the reduction of in colloid osmotic pressure in this scenario has very little effect on total osmolality, whereas the reduction of osmolality has an enormous effect in the brain on water movement. You know that because we always say do not use hyper osmolaltic infusions. And indeed, the albumin used in Australia and New Zealand has a plasma osmolality of 250 milliosmol per kJ. So this is a hyperosmolaltic infusion fluid. So be careful when you have to be really detailed in like this to really see what is the truth in all these studies. I think this is the reason why albumin was in Australia so deleterious. I think it's nothing to do to use a colloid or not a colloid. Trauma trial. Some data from about starch in trauma. This was pre-hospital in South Africa. They used in penetrating and blunt injury haze or abnormal saline. They needed more saline than starch. Blood and FFP platelets were similar. They measured the lactate clearance as a marker of tissue hypoxia and found, at least in the penetrating trauma, that there is an indication that the use of starch was maybe a little bit better than the use of the saline. What was interesting in this rather small trial was that there was no increased renal injury or failure using starch in this scenario. And just to show one trial from the hypertonic discussion, there are pros and cons trials. I show you here a well-designed con one who showed no increase outcome benefit using hypertonic saline against Ringer's lactate in trauma brain injury patients. You can see here 6 months Glasgow Coma outcome score without any difference. There are some other trials showing a small advantage, but to be honest, I'm personally not particularly convinced. You know that we have now the recommendation of the of the EMA, Medicine Agency, not to use starch in critically ill and septic patients, but it says starch could be continued in patients with hypovolemia caused by acute blood loss, so hence in hemorrhagic shock and trauma patients. And I will conclude now here with recommendations where Roy Frosson is part of this group of management of bleeding coagulopathy following trauma. So yes, please do start with fluid therapy initially crystalloids, and please do not use hypertonic solutions. And Ringer's lactate also is a hypertonic solution, or the Australian albumin. And yes, from my point of view, yes, use collars in this situation, but stick to the recommended dose. And hypertonic solutions, they suggest that it can be used, but it's no demonstration of an advantage. And it should be really probably stick to the penetrating trauma, not to the blunt trauma patients. So fluid resuscitation in conclusion, time is tissue. Please use balanced fluids. I think personally shock is an indication for a colloid. Define your treatment goal. This is true for all patients, including the trauma shock patients, and use oxygen delivery and tissue perfusion goals. This can be maybe then the lactate clearance as your treatment protocol. I think it's important that we have an indication when to start and a target what we want to achieve. Thank you very much for your attention. Please do not forget, this is not black and white. This is very colorful what we're doing. Thank you ever so much.